give his credit card over the phone to them, so he would. But that's how we ended up doing it. And the child had at least 2 ER visits in a hospital stay. Under therapy services, we fight the battle every day that we have children who need to be evaluated for speech, for physical therapy or disabilities, for occupational therapy, which is fine motor. We have all of them need to be evaluated. We don't have uniformity across the insurance companies of those 4 who will how that's handled. We have different forms, they have different ways to handle it. We need uniformity. We need them to be guaranteed, and I think they do guarantee the evaluations, but we need them to be able to go through the same process that we used to for Medicare Medicaid, which is to state medical necessity, sign the form, have the review organization, which is presently eHealth, review the thing for medical necessity, and then say, yes, we agree with you, doc, they need therapy. We don't need companies that say we don't cover speech or we don't cover this or that. And we have definitely had therapists who have been experiencing difficulties accessing the different companies. We have durable medical equipment companies that we don't need to lose. We don't have enough of them now. They handle all sorts of things. They handle diapers, enteral feeding tubing sets, the food products, the tracheotomy supplies. They handle the wound care supplies. We have one company that I queried who's owed $100,000 in Medicaid programs, not just one, all of them, for the last 2 or 3 months. Now, he can't live that long without saying crying uncle and quitting serving the population if he's not reimbursed. And as I said, we've had medical homes, and we have medical home issues, and we want you to know that a child's parents in any Medicaid program, I use the number 85% of them. 85–90% of them are going to latch on that medical home and say, thank you very much, I love you as a doctor, this is where I want to stay. And if they want to shop around, they can shop around and find the next doctor they want to go to. But they're going to find someone they're happy with. And when they're happy with them, and you can provide them after-hours telephone answering services and after-hour nurse triage systems, like we have one that's literally based in North Carolina who talks to patients through the pediatric profile of what they call pediatric triage medicine. When you find that, they're going to decrease their use of the ED. Now, yes, they will use the ED, and more than we want to, but it has more to do with what they need to do after hours if they use our telephone service and we say don't go to the ER, you can manage this over the phone, we'll see you Monday morning, the majority will do that. So we need to, as Ms. Trooper said, we need medical homes. Everyone has said today actually. We need medical homes. The root of the problem might be that we simply need to pair the patients up with the ones that are, and I know there's not enough across Mississippi who can bear the entire burden in the underserved area, and that is not, but we do have various and sundry other ways of handling it. So I think that the bottom line is that we find a medical home and find people who are conscientious about addressing their many issues. Thank you.
Lady from Lincoln for a question, then the gentleman from Forest.
Thank you, Doctor. I just have a question. I think what the legislators are confused about, and I just want your personal opinion, and I realize that we're just going on based on our personal opinions here, because we can't get numbers, we're just kind of going on personal opinions. There's going to be a loser when you say you can have more visits than regular Medicaid provides. You can go and have glasses, and you can have this, you can have that. There's going to be a loser. Either Medicaid's not going to save the money that they think they're going to, the patient isn't going to get the services, or the provider is not going to get paid for those services. But there's going to be one. Is it, in your personal opinion, the patient that's losing, the provider that's losing, or all of the above?
I think it's all of the above. The patient is losing because it takes them longer to get those medications approved than it should take them. The doctors lose it because we're filling out paperwork after paperwork, not quite as bad as one patient, piece of paper for every patient for every.
So with 5% for the division of Medicaid, is this really going to be worth it? Probably.
Yeah, I think that's what this is going to reveal. I think that's what we will be looking at. In the first year, obviously the savings aren't going to be as significant as they will be down the road because you're trying to change behavior, changing efficiencies. But ultimately, I think you've got to do something different. As Ms. Pruitt was alluding to, we've gone years and years and years trying to do things a certain way. This is a change in program design. And this is something that I think, at some point you've got to try to break through the mold and try to do something a little bit different that's had success in other states. We hope that we're able to bring that success to Mississippi. We'll see.
Gentleman from Forest.
I'm going to say mine.
Thank you, gentlemen. Dr. Weisenberg, you've mentioned a lot of things that are specific instances of problems that people have communicated to you. Would you mind sharing that information with the Division of Medicaid so that they can look in to see what the billing problems are and how that could possibly be resolved?
Yes, sir.
I will say this, Dr. Weisenberg is very good about talking to staff. My staff will be routinely they talk with her about various issues.
Yes, I do talk to the Division of
She
Medicaid.
is letting us know about it, so we are able to, because we are aware of the community problems.
She's the squeaky wheel then.
Yes.
We appreciate that.
Lady from Wayne.
I just have one question. You said that the pharmacy lists are all different, for 4 different programs, the CHIPS, the Medicaid, and the MississippiCan, and also that you have different forms to fill out. How hard would it be for everybody to get together and simplify that?
I want one formulary, one form. I don't mind doing generics. I don't mind filling out a list. I do appreciate the Division of Medicaid's regular Medicaid pharmacy programs improvements. In the last few months, I have done 90% less paperwork for them. I don't appreciate having to spend time on the phone just like everybody would, arguing with the pharmacists that are a PA person in another facilities in Pennsylvania. When they don't, and it's not just their problem, it's a nationally driven formulary in some cases. And I want it to be very specific to Mississippi. I understand what the pediatricians, family practitioners, and nurse practitioners need. And that's what I want.
Gentleman from Forest.
This is a question for the Division of Medicaid regarding that subject. I mean, the medicines they cover may be different, but didn't you say that they have to at least provide what Medicaid will pay for?
Yes, they do have to provide it. Now, they have their own preferred drug list. So if they want a drug, if the provider wants to prescribe a particular drug, it's on a preferred drug list, they will contact the plans and receive authorization to get it.
So basically, give me a drug somebody uses. I don't use any yet.
Ours.
How about Plavix? How about that? Can I say that? Even if you cover it or not. All right. So Medicaid covers Plavix. You're saying they don't have to cover that if they have a different preferred drug?
They have to cover it, but normally if a drug is on someone's preferred drug list, then you don't have to seek any prior authorization. It goes to automatic. If it's not on the preferred drug list, then you would have to seek prior authorization.
Except it see certain numbers, like 7 total, 2 generic, something like that.
But that's been all along.
The gentleman from United had something to add to this conversation. Gentlemen, you're recognized.
Thank you, Chairman. United actually has, as I understand it, the same preferred drug list for the CHIP plan as does the MississippiCan program, as is pretty much the same preferred drug listing as its commercial listings. In other words, I, as an employee of United Healthcare, have that same plan, that same PDL, as we say. And I understand Dr. Weisenberg and I have actually had several email conversations and phone discussions about some of these issues, and we'll continue to work with them. But I don't know how effective one global, prescription drug, preferred drug plan is going to be. You have to get all these entities to agree. Ours is consensus-based. In other words, it's based on recommendations from the American Academy of Pediatrics, the chest physicians, etc. And it's generally based on what we call step therapy, which is, as Dr. Weisenberger described, you generally use the agents that are the best tolerated, lowest complications, in many cases less expensive, and then you move on upward as you need to. It's those upward levels where a prior authorization would be required.
Thank you, gentlemen. Dr. Weisberg, do you have anything else to add at this time?
No, sir.
Thank you very much for coming and waiting and presenting. Your paperwork will go in the file for the peer committee to review. Thank you. At this time, we have Dr. Chance with us. Dr. Chance, if you would please come. While she's coming, I want to point something out. The last time we revised the Medicaid Technical Amendments Bill, it was over 90 pages long. We've just spent 3 hours on 4 paragraphs to give you any idea how complicated the Medicaid program is. Thank you, Dr. Chance, for coming. If you would, you're recognized to begin.
Hi, I'm Jerry Hill Chance. I'm a child and adolescent psychiatrist in Hazelhurst, Mississippi. And the reason why I'm here is because since January 2011, I have been almost in tears every day trying to get medication for my patients. And even though the gentleman from United Healthcare said that it's the same whether they're on regular United Healthcare, CHIPS, or the CAN program, that is not true. It's not true in terms of even reimbursement for CHIPS. There are some of my patients that are on regular United Healthcare insurance. I get reimbursed for that, and I don't get reimbursed for CHIPS. And so it's not exactly the same. I wrote a letter to Dr. Robinson, the division, who is over the Division of Medicaid, and I sent copies to some of you, so that's why I'm here, because Representative Curry asked me to come. And prior to this year, I really was impressed with the Medicaid system in Mississippi in terms of getting medication for the children. Even though there were some children that I had to do prior authorizations for, it was a very seamless process. I'd fill out one piece of paper, I'd fax it to Health Information Design, and within 48 hours, I would either get an approval or a denial. Right now, there's a child who has been on medication for 2 years, 6 weeks later, and I still have not gotten an approval or a denial. I don't know where he is. He's in some kind of medication limbo. And the problem with that medication is because he is below FDA age guidelines for this medication, he has not been able to get it, even though it is a generic, and he's on regular Medicaid. Prior to December, he had the medicine. I wrote the prescription in January when he came. He can't get it. I filled out the paperwork. My office manager inputs it on the website. We go back to check. Don't know if he has it. And then we call and they said, well, we don't know why he can't get it. I don't know why he can't get this medication. And now it's been 6 weeks. The father, because it is a generic, the father is able to afford it and has been able to get it. But it's very frustrating for him because he doesn't know what the problem is. In terms of Vyvanse, Magnolia Health Plan does not cover Vyvanse. There is a child that was on Vyvanse, and because he is in foster care, he was switched to Magnolia Health Plan, and now he can't get the Vyvanse. And to say that you suggest that we start at a medication that is a generic or cheaper, that may not be the best for my patient. And I have been practicing child psychiatry in Mississippi now for 15 years. And I think for 15 years, for seeing kids, I shouldn't have to say, okay, well, Ritalin is the cheapest, I'll go with this. When I already can look at the child and say, you know, he would do better with Concert, or he would do better with Vyvanse. Why do I have to start at the cheapest but do it for a month when I already know that it's not going to work? You know, Adderall, the 5 milligram Adderall is the cheapest, but it's also what they use to make methamphetamine. So So, make crystal meth. So why would I prescribe that when I can prescribe Vyvanse, which has least potential for abuse? So I just don't quite understand how you just kind of arbitrarily decide what medication, as a psychiatrist, I can prescribe. We have so few things that work. And the few things that do work are not on the drug list. And then I'm told, well, don't give Intuitive, which is the new non-stimulant medication for ADHD, use 10X. Well, I already did that, and I was so happy that something came out. But Magnolia Health Plan's pharmacy, doctor of pharmacy says, well, you should try 10X first. I already did that, but you didn't use the maximum dose. But I see that this child would do better with the long-acting, so why do I have to go step by step, like I'm following a cookbook, when part of the reason why I became a physician is so that I can help people. And part of being able to help people is that you come in, I talk to you, I look at you, I listen to you, and I think, well, this will be the best medicine for you. But if I have to just go through the cookbook, then I'll just have my patients just call the people up at the prior authorization desk and say, well, you can take this, and they can just, skip going to see the doctor if the prior authorization desk is going to be the one to decide what they can and cannot take. Let's just save money for Medicaid, have no physicians at all, and just let the people at, the prior authorization desk decide the medication. And so then the other concern is that Magnolia Health Plan has one form I fill out for prior authorization. United Healthcare has one. I bought each one of these plans with me sheets of paper. And then Medicaid doesn't have a form anymore. I have to go on the website. But while I'm on the website, while I'm seeing patients, that used to be something my office manager could do for me, just, fax it in. But now, then I have to take time to either fill out the old form and still let her input the data and then wait and wait and wait and wait to get a response where it used to only take 48 hours. And so now you have patients that go longer and longer, and these are the children who are disrupting school. They are probably getting into fights. Now they have to go to the detention center because they can't get their medicine. And like I said, there's so few medications that do work in psychiatry that when you find something that does work, because we're trying to strictly adhere to the FDA age guidelines, which I don't have a problem with, but once I say the child needs it, then that should be sufficient. But then one of the things that happens with Magnolia Health Plan is that I will fill out the form and then they will say, we'll send the records to prove that this child was taking the medicine. Why would I lie that the child took the medicine before? There's no benefit in me lying. And so then that's another step that I have to take. And as a psychiatrist, I'm not comfortable faxing records, in terms of people who have psychiatric illnesses. They may tell me some things that I just don't want to share with the people at U.S. Script in California. I'm just not comfortable with that. And so I said, well, why don't you have access to like a pharmacy profile, which will just say, well, this patient had this medicine 2 months ago. Why do I have to send the whole notes? Isn't there some kind of software that you can use that will just access, the pharmacy profile? And so I don't understand why it has become such a cumbersome, inefficient system. It's not in terms of patients coming to see me, because that's not a problem. I still see my patients, and so that's not a problem. The main problem is in terms of getting the medication they need, because it's hard enough for patients to get mental health care as it is, because there's not a lot of child psychiatrists in the state. And so once they're able to come, now I can't get them the medicine they need. So even though I'm not the barrier preventing them from being served, now the barrier is the medication. And so that's why I wrote the letter saying, prior to this, I was really pleased. I thought, man, Mississippi Medicaid has it going on. My colleagues in other states were complaining that they couldn't get the medicine. I'm like, oh, no, I can write a prescription and fill out my little prior authorization and everything is cool. Not now. I'm complaining with them. So it's just, you seem like maybe you've improved in some areas, but in terms of psychiatry, it has not been an improvement. It has been not good. And so that's basically what I want to say.
Dr. Chance, I just put two and two together. I just realized that you were the person who had forwarded me the letter on this subject. How do you pronounce the name of the?
Maecenas.
Maecenas?
Yes.
Okay. What's the story? What's the history of that word? What's that? What kind of?
I needed a name. I flipped through the dictionary. I said, "Oh, that's pretty."